Morning, everyone. Morning. Thank you for joining this morning for our grand rounds. My name is Fiona. I'm one of the medicine chiefs, and I'm very happy to introduce our speaker today. Dr. Uroosa Ibrahim graduated from medical school in Karachi, Pakistan, following which she did her hematology oncology fellowship at Northwell Health and her BMT cellular therapy fellowship here at Mount Sinai. Dr. Ibrahim is currently an assistant professor of medicine in the Division of Hematology and Medical Oncology, the associate director of the cellular therapy program at Tisch Cancer Institute, as well as the gene therapy lead for sickle cell disease and beta thalassemia here at Mount Sinai. Dr. Ibrahim's clinical focus is on stem cell transplant for ALL and benign conditions including MS, sickle cell disease, and thalassemia. She also performs CAR T-cell therapy for leukemia and lymphoma patients. Dr. Ibrahim's research focus is on complications and outcomes of CAR T-cell therapy and outcomes of curative modalities for benign hematological diseases. So thank you for joining us today, and I'll bring up Dr. Ibrahim.
Thank you for the introduction and thank you for having me. No disclosures. This is the outline of my talk, background, pathophysiology, clinical features of sickle cell disease, and we'll discuss some data and procedures in transplant and gene therapy for sickle cell disease. And we'll go over the treatment journey for individual patients with some case-based vignettes. And starting with the first one, a 26-year-old Black female with a diagnosis of sickle cell anemia, SS genotype, and history of migraine headaches, vaso-occlusive crises since childhood, avascular necrosis of right ankle, and recurrent pulmonary embolism treated with apixaban is referred for curative therapy. She has been taking hydroxyurea since age 7 and underwent monthly red cell exchanges until adolescence. The patient has had weekly ED visits, which she tries to avoid now and manages crises at home. For pain management, the patient takes gabapentin, duloxetine, oxycodone, methadone, and tizanidine, several of these multiple times a day, and is still not pain-free. So sickle cell anemia affects millions of patients worldwide. In the United States, the prevalence is about 100,000 individuals at any given time, and in the EU, about 52,000 individuals. The global incidence is about over 300 to 400,000 infants being born annually. The history of the discovery of sickle cell disease goes back to 1910, where elongated sickle cell erythrocytes were first discovered in a dental student at the University of Chicago who had pulmonary symptoms. This student had immigrated from Africa at the time. It took another 20 years to figure out that these sickle cells were clogging up blood vessels and causing pain symptoms. In 1949, the hemoglobin that causes the sickle-shaped erythrocytes was discovered. And then in 1957, the single amino acid substitution that causes hemoglobin S was discovered. And in 1970s, the single nucleotide mutation that causes hemoglobin S was found. The disease remained neglected for many years thereafter until the civil rights movement, where they called attention to racial inequality in healthcare. And it was the Black Panther Party that set up screening clinics, particularly in this Black community. And the goal was to diagnose patients earlier, refer them for establishing care, and counseling of families. In a lot of these clinics, it was pre-med students who had volunteered. Structural racism and interpersonal racism is very well described in sickle cell disease. A study in 2013 showed that Black patients with sickle cell disease wait 25% longer in the ER than patients, other patients of other ethnicities before receiving care. Another study in 2020 showed that Black patients are 22% less likely than white patients to receive the pain medication they need. So sickle cell disease is a genetic disorder associated with episodes of acute illness and progressive organ damage, essentially leading to accelerated aging. The normal hemoglobin structure comprises of hemoglobin A, 2 alpha, 2 beta chains. These are polypeptide chains. They comprise 96% of normal adult hemoglobin. Then there's a small percentage of A2, which comprises of 2 alpha and 2 delta chains, 2 to 3%. And then there's F with 2 alpha, 2 gamma chains, which predominates in the first year of life. And then along with the heme and iron, they form the hemoglobin molecule. The HBB gene on chromosome 11 encodes the hemoglobin beta chain, which forms the hemoglobin A along with alpha chains. In sickle cell disease, for hemoglobin S, the beta chain has a single nucleotide mutation between adenine and thymine, which results in a single amino acid substitution from glutamine to valine. And this forms the hemoglobin S, which when undergoes deoxygenation, it forms polymers. And these polymers damage the cytoskeleton and they damage the plasma or cell membrane, which leads to the sickled shape of the RBCs. And also they expose the cell surface glycoproteins and glycolipids, which when interact with the endothelium, they increase adherence to the endothelium. And when they interact with leukocytes, they attract leukocytes and cause adherence of those to the endothelium as well, leading to inflammation. These rigid RBCs obstruct the microvasculature, causing tissue hypoxia, which precipitates further sickling. These sickled cells hence have a shorter lifespan of 20 to 20 days as opposed to the 90 days of normal RBCs. So there are several types of sickle cell disease. The most common and severest form is sickle cell anemia, SCA, which is the homozygous form where both beta chains have the S mutation. Then there's trait, where one beta chain is S, the other is the normal A, and there are no symptoms unless the cells are under low oxygen tension. Then there's sickle beta thalassemia, which is heterozygous, where one beta chain is S, the other may have the beta deletion, or which is beta 0, or beta mutation, a beta plus. This is a mild form. Then there's SC disease, which is a heterozygous form also. There's one beta chain that is S, and the other one is C, which is a similar mutation to S, but the amino acid substitution is from glutamine to lysine instead of valine. And this usually is a mild presentation, but when we see patients for curative therapy, they usually have severe form of the disease. The sickling in, so trait and C disease do not have sickling. SC has less sickling than SS. Okay. So the inheritance pattern, as we could tell, is autosomal recessive. So parents with the trait have a 25% probability of having a child with sickle cell anemia, and then 50% probability of having children with trait. Same with C and S, 25% probability of having a child with SC, and same inheritance pattern for sickle beta thalassemia. This is important when we talk about donors, potential donors for patients. Clinical features are a result of vascular occlusion or chronic hemolysis. So when we look at organ systems, head to toe strokes, these can be ischemic strokes or conversion to hemorrhagic strokes, retinopathy, blindness, acute chest syndrome, which most of us are aware of, autosplenectomy leading to susceptibility to infections, especially encapsulated infections, renal infarcts, papillary necrosis, aseptic bone necrosis, priapism, osteomyelitis, especially in patients who have undergone autosplenectomy, leg ulcers, and dactylitis. Effects of chronic hemolysis are mainly because of iron overload, congestive heart failure, jaundice, chronic hemolytic anemia, and pigmented gallstones. The primary reason for hospitalization is crises, which include vaso-occlusive crises, aplastic crises, and hemolytic crises. So over time, as we can tell, these patients develop chronic organ damage, and in about 50% of adults, this is related to cardiac failure, pulmonary failure, or renal complications. So about 26% of deaths in adults are related to cardiovascular causes, 32% of cause of death is from pulmonary causes, and then 19% from renal causes. And as a result, adults with sickle cell have a shortened lifespan, about median survival of 48 years, and there has been no change in the last 25 years. On the left is a graph from 1994 with the life expectancy, and then on the right is one from 2019, and there has been no change in the life expectancy despite approval of certain therapies. And this survival is poorer in individuals who have multi-organ impairment. So patients with one single organ impairment are, the difference is about 7 years when patients have more than one organ impairment. So since its discovery in 1910 initially, there have been 4 drug approvals. The first one was hydroxyurea in 1998. And then in the past 7 years, there have been 3 drug approvals: L-glutamine, crizanlizumab, which is a p-selectin inhibitor, and it had shown to decrease frequency of pain crises in adults, and it was approved for adults over 16 years of age. Voxelotor decreases hemoglobin S polymerization. This was approved for patients 4 years of age or older with sickle cell disease. Voxelotor was linked to VOCs and death and was actually withdrawn from the market last year. The HOPE Kids 2 study showed of 236 children treated, 8 patients died versus 2 on placebo. In the RESOLVE study, 8 of 88 participants died. So patients have been subsequently tapered off this medication, and so we're actually one less drug. And then crizanlizumab, the phase 3 trial failed to confirm clinical benefit, so its market authorization, it was revoked in the EU and UK, and it's also fallen out of favor in the US. So basically, the 2 medications you had are not there anymore. So there's more of a dire need for curative therapies because of that, and then the median life expectancy, which remains unchanged. And an ideal curative therapy has to have high efficacy rate, acceptable toxicity profile, and needs to be accessible for all patients. Moving to our second case, a 32-year-old male, accounted by profession, has SCA, SS genotype, complicated by recurrent VTE, acute chest syndrome, on MRA head found to have cerebellar artery stenosis. He has been hospitalized with pain crises 8 times over the past year, has declined hydroxyurea because of possible side effects, takes Dilaudid 4 milligrams orally every 4 hours as needed for pain, and the patient requested a referral for gene therapy. The patient has 4 full siblings and 2 paternal half-sisters. When we saw the patient, we did HLA typing. 1 sister is a full match, and 1 brother is haploidentical. So what do? Continue supportive care, start red cell exchanges to prevent crises, HLA identical bone marrow transplant, or autologous gene therapy. So the 2 curative approaches are allogeneic transplant, where donor cells are used to replace the patient's hematopoietic and lymphoid system, and then autologous gene therapy, where the patient's stem cells are genetically modified either by adding a gene or editing a gene to correct the defect. And we'll go into that more. So allogeneic transplant involves finding a suitably matched HLA donor, which can be a sibling or who's a half match or a full match, and we'll discuss data for both. The donor undergoes clearance and collection of stem cells, which can be from peripheral blood or bone marrow. The stem cells are processed and undergo cryopreservation or can be used fresh. The patient is admitted to the hospital, undergoes high-dose chemotherapy, usually with a combination of radiation, which we call the conditioning regimen. And then the stem cells from the donor are infused. It takes about 2 to 3 weeks for the patient, the recipient, to form a new blood and lymphoid system. And lymphoid recovery takes a little longer. And it basically replaces the patient's stem cells with donor stem cells. Historically, the indications for transplant, as established by the American Society of Transplant and Cellular Therapy, are for matched sibling donors. If you look at it, it pretty much includes every patient that we probably see for sickle cell disease. So recurrent acute chest syndrome, recurrent pain, vaso-occlusive crises, strokes, impaired cognition, neuropsychological dysfunction, elevated transcranial Doppler velocity, red cell aluminization, pulmonary hypertension, osteonecrosis. Pretty much any patient we see would fit some of these criteria, usually more than one. Alternative donor, the list is short, but clinically we do treat patients now based on the data I'll show you next with the same indications as for matched sibling donor transplant. So match-related donor transplant has been there for decades now. Donors are siblings with same parents. The conditioning historically has been myeloablative. It's the most common form of transplant for children with sickle cell disease. Overall survival in several studies has shown to be about 95%, disease-free survival of 92%, and complications 1 in 10 children or 10% have graft versus host disease. This is data from the CIBMTR, 91% survival for sibling donors. This is looking at 3-year overall survival. And then the European blood and marrow transplant, 95% survival for sibling donors. So excellent results. However, a very tiny fraction of patients actually undergo transplant with sickle cell disease in the US. And this is data from the CIBMTR, where about a little over 200 patients underwent transplant in 2023, 2022. As I mentioned earlier, there are about 100,000 individuals living with sickle cell disease. So that makes about 0.2% of patients actually undergoing transplant. The barriers include primarily lack of awareness of benefits of transplant, so physicians and patients are not aware of the option of having being available. Lack of donors, because if you go for matched sibling donors, only about 18% of individuals have a matched sibling donor. And even then, whether or not they would be cleared for transplant, not always patients are eligible to undergo donation. Infertility risk, because most of these patients are young and are childbearing age. And then chronic complications such as graft versus host disease are a deterrent for many patients. And in adults, additionally, since this data is all with myeloablative conditioning, it's deemed very toxic for most adults because they've lived several decades of their lives, 3 or 4 decades, having sickle cell disease, which causes chronic organ damage. So 60% have at least one organ damage, if not more. So what we need is less toxicity and more donors. So in terms of less toxicity, the NIH developed this approach of conditioning, which is chemo-free. It uses the CD52 antibody, anti-CD52 antibody alemtuzumab, with total body irradiation, a small dose of 300 centigrade. This showed overall survival of 79% and event-free survival of 68.6% at 2 years, which is not bad, but there's better data for Haplo now. And the problem with this was increased risk of graft failure, about 11 to 14%. And in the real world, we see now that it's as high as 25%. Mixed chimerism, which is the percentage donor cells versus percentage recipient cells, was 48%, and which increases risk of malignancy just because of the hostile bone marrow environment that it creates by having multiple cell populations. This protocol was since discontinued, and it's not used in children at all. In adults, in patients who are late 40s, 50s, who cannot have any other conditioning regimen, we are sometimes using this. So, and how do we increase the donor pool? So historically, identical sibling was the standard of care, but if we include half-matched or haploidentical siblings, that really increases our probability of finding a donor. So if we include half-matched siblings, that increases the chance of having a donor by 75%. And we can also include parents, typically patients who are in their 20s. They have young parents who are in their 40s, and this really increases the chance of finding a donor for patients. So the first study that was done with half-matched transplant was at Hopkins with this conditioning platform that had ATG, fludarabine, cyclophosphamide, small dose of TBI. This had a high graft failure rate of 43%, which is even higher than the fully matched one, 14% mixed chimerism, but there was no cure to chronic GVHD and no mortality. So this meant that the conditioning could be improved upon. And there were 3 approaches that were taken to build up upon this conditioning platform. The first one was the Vanderbilt consortium that added thiotepa, 10 milligrams per kilogram, just to increase the intensity to improve upon graft failure. Hopkins revised its own approach by increasing the TBI dose to 400, and the BAMT-CTN study added hydroxyurea preconditioning for 2 months, and then also added thiotepa, similar to the Vanderbilt consortium. And I'll discuss results of the Vanderbilt consortium because this is the one we've been using at Sinai. So this was a study over 10 years, 2013 to 2023, included 70 patients, included adults and pediatrics. The 2-year survival was 94.8%, with no difference between pediatric and adult. 97% of patients were off immunosuppression at 1 year. There were 5 deaths on trial. All 5 were infections. 2 were COVID, because this included COVID time, and then 2 were disseminated adenovirus infection, and the 5th one was also a form of pneumonia. The 2-year event-free survival was 82% for both pediatric and adults, but for adults it was 94%, pediatric 68.4%. So there is some difference in the pediatric and adult cohort, which means that the pediatric cohort further needs to be improved upon. The graft versus host disease rate was 7 total in each group, so 10%. This is similar to matched sibling data. And the 4 cases of primary graft failure and 4 of secondary graft failure were all in pediatrics, so no graft failure in adults. So in pediatrics, as I mentioned, we need to improve upon. So there's early data that is showing preconditioning with hydrea and hypertransfusion is actually improving overall survival and disease-free survival in pediatrics. There's data to show that there is actually organ reversal after transplant. And this study is one example of that, where cerebral hemodynamic changes after transplant, the changes that happen pre-transplant can be reversed post-transplant. So if you just look at this CBF, which is cerebral blood flow, what happens in transplant patients with sickle cell disease is that there's low oxygenation, oxygen carrying capacity by sickle cells. So what happens is cerebral blood flow increases to compensate for the low oxygen. So pre-haplo-BMT, the cerebral blood flow is 67. That's ml per 100 gram per minute. In healthy controls, about 47. After transplant, this goes down to the level of healthy controls. So that's a significant improvement. The oxygen extraction fraction, no significant change, but that's expected because the blood flow was increasing to improve oxygenation. So basically, the cerebral blood vessels compensate to increase oxygen extraction fraction. Everything else, if you note, hemoglobin significantly higher, and hemoglobin S significantly lower. And this is just the imaging of the same. The red, orange, yellow is the angry looking cerebral blood flow, which is high flow, over 50. And then post-transplant, it decreases to less than 50, which is the blue, purple. Similarly, in patients who have pulmonary hypertension, this was a report where it was possible to reverse it post-transplant. So the pulmonary artery pressure went down from high levels to normal levels 1 year post-transplant. So same thing with pulmonary artery wedge pressure, right atrial pressure, hemoglobin pro-BNP. One thing here to note is that the left ventricular ejection fraction was slightly lower before versus after transplant, which sometimes we see in patients post-transplant with the toxicities related to the conditioning, which is this list. Whenever we see patients, we discuss the possible toxicities. Not every patient gets all of them, but every single organ can potentially be affected by the chemoconditioning or graft versus host disease and other possible complications. Going back to the case. So this is the patient who came into us asking for gene therapy. We typed the siblings. One of them was a full match. We had several discussions. We discussed data in matched sibling transplant and haplotransplant and gene therapy. The patient was convinced that he went for a second opinion, and he talked to friends and family and whatnot, and we decided that since there's so much long-term data with matched sibling transplant, this is what we would proceed with. He was not on Hydrea before because he was concerned about side effects, but we started Hydrea just in order to improve to engraftment to prevent graft failure, which he agreed to doing, and patient underwent monthly red cell exchanges to prevent crises going into transplant. He received the conditioning, which is the Vanderbilt Consortium 1 flu cythiotepa ATG TBI with post-transplant cytoxin. The most significant complication he had was grade 4 mucositis requiring hydromorphone via PCA pump. By day 90, actually early on too, but it stayed, day 30, his chimerism, which is the percentage donor cells, was 100%, and it has remained so now. This was his hemoglobin electrophoresis. So pre-transplant, A was 9.1%, post-transplant 97.6%, and S was 80, and post-transplant 0. This also tells us that the patient's sister did not have trait. This is the third and final case. 40-year-old male with sickle cell anemia, hemoglobin SS disease, diagnosed at age 2, treated with monthly red cell exchanges, complicated by avascular necrosis of the right hip and pain crises ranging from 2 to 5 per year. The patient has a haploidentical sister who has autoimmune disease. Patient is interested in gene therapy. He says, I will take any risks, but I do not want to live with this anymore. So for gene therapy, there are two FDA-approved strategies. One is gene addition, which uses a lentiviral vector to package a normal hemoglobin gene and insert it into a blood stem cell that integrates into the nucleus and forms normal hemoglobin. The other approach is CRISPR-Cas9 mediated disruption of BCL11A enhancer. This basically increases in endogenous hemoglobin F production. So the two FDA-approved products are Lovoti-Beglogene Autotemcel, Lovocel for short, Lyfgenia is the brand name, and Exagamglogene Autotemcel, Exacel, and Casgevy is the brand name. So gene addition, which uses the vector system, which is lovo-cell, what happens is stem cells are collected from the patient. A normal hemoglobin A gene, which is manufactured also, is inserted into a lentiviral vector. This vector is introduced into the stem cell. It translocates to the nucleus, and this gene integrates into the DNA of the recipient stem cells. This leads to transcription, translation, and formation of the normal beta globin gene, which forms the normal hemoglobin then, and a functional RBC. This hemoglobin A is called T87Q. It's very similar to normal hemoglobin A, but it has a single nucleotide substitution at amino acid threonine to glutamine, so it's named as such. It cannot be used with in patients who have a 2-gene alpha thalassemia. That's because you need functional alpha genes to form a normal hemoglobin molecule. And of course, antiretrovirals cannot be used because you need the viral integration into the DNA. So the study that looked at lovo-cell had several groups of patients. It was a phase 1-2 clinical trial. The initial cohorts were A, B1, B2. So every cohort had different protocols, mobilization collection protocols, drug manufacturing processes, and busulfan, AOC goals. Busulfan was the conditioning chemo that was used. So it basically was a refinement of the process with each subsequent cohort. Group C was the final one, which was the commercially approved procedures for the drug. It used plerixafor mobilization, which was not used in the previous cohorts. Plerixafor is a CXCR4 inhibitor, which improves the release of stem cells from the bone marrow. And group C had apheresis, which is peripheral blood collection rather than bone marrow collection, which was done in the previous groups. It used an increased cell dose, and it's also used an increased chemo dose, because there were a lot of failures in the previous cohorts. So the patients treated were between 12 and 50 years of age with a diagnosis of genotype SS, S beta 0, and S beta plus. So this shows the red triangles are VOEs, and the red circles are also VOEs, and this 0 is the time of infusion of the drug product, and these are VOEs prior to infusion. And everything else is after infusion of the drug product, and you can see the difference in terms of patients not having VOEs. So 47 patients were infused as of February 2023. 34 were evaluable for VOE endpoints. 94% patients experienced complete resolution of severe VOEs in the 6 to 18 months post-infusion, and 88% has resolution of all VOEs, severe and non-severe. And all patients who had VOE resolution had maintenance of that resolution. This was an update that was presented at ASH last year, 84 months of follow-up. And this showed sustenance of VOE remission, including all VOEs, 86.8%, and severe VOEs. So CR was 94.7%. 100% of pediatric patients had VOE CR. So this shows the green here is the patient's hemoglobin, which could be SS, S beta 0, or S beta plus. And the red is the one that the transduced gene is forming, the T87Q. So two things to note here are, one, the total hemoglobin goes from baseline to about 10 to 12, even a little higher than 12 in some cases. And the second thing to note, of course, is that the A forms to about 40 to 50%. Some, when we see patients, the expectation is, we're going to have all the new hemoglobin A. But that doesn't happen because the viral vector is transduced not in 100% of cells. There's a percentage. There are criteria for commercial release, which is 60%, but it could be less or higher than that. So patients will be expected to have a trait-like picture, which is sufficient to prevent crises and long-term complications. So that was lovo-cell, the viral vector manufacturing that is used. The other one is gene editing, which uses the CRISPR-Cas9 system, which is a genome editing system derived from certain bacteria, and in combination with an enzyme system, they are able to edit genes. So what happens here is, same thing, stem cells are collected from the patient using a technique of electroporation. Cas9 single guide RNA is introduced into the stem cell. Now, for the idea is to increase endogenous hemoglobin F production. Now, what happens normally is that you have BCL11A, which is high in amount, and it suppresses hemoglobin F production by suppressing gamma chain production. So what this does, the Cas9 single guide RNA does is, it shuts off the BCL11A erythroid enhancer. When it shuts off that, it decreases production of BCL11A, which in turn enhances gamma chain production, therefore it increases hemoglobin F production. So less 11A, less of the enhancer, reduced BCL11A, high gamma chains, increase in hemoglobin F. The trial that looked at this was the CLIMB trial. The primary outcome was looking at VOCs again, vaso-occlusive crises, for absence of VOCs for 12 months in the 24 months of follow-up period. 97% of patients treated were free from VOCs in the initial results. 30 out of 30 patients free from hospitalizations for 12 months. This one, the blue diamonds are the crises, severe crises pre-treatment, and then post-treatment, again, significant improvement. And this was an update of this trial. This is 48 months of follow-up, and this one is 60 months of follow-up. This 5-year update was presented recently at TCT. It showed durable VOC-free benefit in 93% of patients, 39 out of 42. The mean duration of VOC-free period was 30.9 months. I'd like to mention, we've had patients who come and say, we don't want to be in the 3, so we don't want this. So every number matters. The 3 participants who did not have VOEs, and then we of course mentioned these things, still had some form of benefit. If they had some pain, they had no reduced hospitalizations. They didn't have any significant severe complications such as acute chest syndrome. And then the patients who still had pain had identifiable triggers, which were infections, procedures, or steroids, or other triggers. And durable hospital-free benefit also at 5 years. So 98% patients achieved hospital-free time of 12 months. So here we're increasing hemoglobin F, and what you note here is that the total hemoglobin goes up significantly, and the difference between this and Lobocel, the prior product, is that here probably the hemoglobin goes up, total hemoglobin goes up a little higher. There it was between 10 to 12, average of about 11. Here, most patients had over 12, which sometimes is also a patient preference. And the F percentage is also about half of the total hemoglobin, which is again sufficient to prevent crises. So adverse events, the list of complications is long. It's similar to what is expected of myeloablative conditioning, which we use for transplant patients. They can be divided into 4 major categories: cytopenias requiring transfusions, infections, GI toxicities, and pain. Similarly, with Lobocel, the conditioning is the same with both products, busulfan. So same list of complications with one exception, a major exception, where there were 2 cases of acute myeloid leukemia in patients who received Lobocel, the lentiviral-based product. And we'll talk about those 2 cases. So comparison of these 2 products, in the trial, the age range for Lobocel was 12 to 50, and Exacel was 12 to 35. But both products are approved for over 12 years of age. The mechanism, as we saw, is different. There's a black box warning with Lobocel of hematologic malignancy. The cost is slightly different, $1 million. There are more treatment centers for Lobocel that are treating right now, and there's more, the length of available follow-up is longer for Lobocel. So the 2 cases of AML, it's amazing how patients, when they come in, I think about 50% are aware of that, and they've read about the cases, and they just know, and they want to talk about it. I've had patients ask, like, randomly, nurses and whatnot. So it's important for everybody to know about these. Both cases were in group A of the cohort, which means that the procedures were significantly refined thereafter. So it was in the early cohort of patients in the study. The first patient was 42 years of age at initial consent, developed MDS AML 3 years post-treatment, so 45 years of age. Now, in between that, the patient actually was not cured of sickle cell disease, still had anemia, had to be started on hydroxyurea, was on erythropoietin-stimulating agents. So still continued to have sickle cell disease. So when, and then the lentiviral vector cell percentage was 22%. The number that is good for release, commercial release, is 60%, which means if there is less percentage of vector, that means more replication cycles are needed to form the normal hemoglobin. So that's also suboptimal. And there was very little hemoglobin derived from the infused stem cells. The busulfan was under target, which means there may have been residual unablated cells, stem cells. The blasts did not have viral integration, which means these were residual cells which had persisted post-chemo. And the blasts were monosomy 7 positive, which is known to be associated with alkylating agents. The second case was 25 years of age at treatment, developed AML 5.5 years after gene therapy. Same thing, was not cured between that time period. Very little hemoglobin derived from the infused cells. Multiple mutations, also had monosomy 7 in the blasts, had RUNX1, PTPN11 mutation. This patient had vector integration into the blasts, which means the leukemia was derived from the modified stem cells. But this integration was in a VAMP4 gene, which is associated, it's not an oncogene, it's associated with the Golgi apparatus, and it was a non-coding region of the VAMP4 gene. So in both cases, it was concluded that it wasn't the gene induction that was directly associated with the cancer. I mean, if you're curious, the first patient, both patients underwent transplant. The first patient had relapse 6 months post-transplant and was started on HMA venetoclax. The second patient had transplant, relapsed, and then unfortunately died. So, I mean, this is an important discussion when we see patients for transplant or gene therapy, but what patients kind of sometimes don't really realize is that just having sickle cell disease increases risk of cancers by sometimes, 7 to 11% in some studies. And those risk factors inherent to the disease are host factors such as chronic hypoxia, endothelial damage, chronic inflammation, erythropoietic stress, and CHIP mutations some patients are known to have. And then there are transplant-related factors, which are similar to transplant and gene therapy when it comes to chemo, radiation. When patients have graft failure after stem cell transplant, then that increases risk of secondary cancers. So just having sickle cell disease, risk of cancers, and then additionally any form of treatment would increase the risk of cancer. And this was a study that a comparison of HLA-matched sibling transplant, haplo, and gene therapy, where they looked at hematologic malignancies per 100 years. And it showed what I just said, that they all have risk of secondary malignancies. This is a little higher with HLA-matched just because this conditioning that is no longer used is just associated with graft failure, mixed chimerism, and more cancers. So patient's treatment journey is long. When we first see the patient and we discuss all treatment options, the average time prior to decision making is about 2 to 4 visits over 2 to 3 months. We do workup for all patients and insurance authorizations needed for transplant or gene therapy. That takes up to 4 to 6 months. There's this basic workup we do for all patients. They all have some form of chronic organ damage, and I feel like even when we don't see them for curative therapy, they should all be undergoing this workup. And this is the bare minimum. Most patients have some abnormality on all of those, more than one of those. And then they require further referrals, for example, neurology, pulmonary, cardiology, and whatnot, hepatology. Once we decide that, say, this is for gene therapy, that we have to do the gene therapy, what we do is the patient undergoes this pre-mobilization transfusion regimen, which is red cell exchanges once a month for at least 2 to 3 months. This is just to prime the bone marrow for us to be able to collect stem cells and then to give chemo and give stem cells back. Then we admit the patient to the hospital for mobilization and collection of stem cells. That is typically a 4-day hospitalization. The first day patient undergoes a red cell exchange, and then day 1 and day 2 are collection for the product manufacturing. Day 3 is collection for backup cells. We send the cells for manufacturing. That takes about 3 to 5 months. And then once the cells are ready, the patient continues red cell exchanges monthly during this time period. We admit the patient to the hospital for busulfan myeloablative conditioning. The product is infused post-conditioning, and then the engraftment reconstitution time is up to 36 days, and it can be up to 2 months. We follow the patients mostly indefinitely. In the study, 13 years of follow-up was required. What we've seen is that patients usually require more than one mobilization cycle. So when you're collecting stem cells, there have been failures for collection and manufacturing. So most patients require more than one collection cycles. And thankfully, we haven't had that experience so much, but in the real world data, we have consortiums where we discuss experiences across institutions where the recollection rate is up to 70%. So how do we decide what treatment to do? Every patient is different. Their situation is different. Their preferences are different. Patients are very particular about, they say we don't want cells from anybody. So there have been patients like that. So basically what we do is we present all the data, we discuss, and it's mutual decision making. I mean, this is a table that I discuss with all patients. This is just a summary of that, but I have like 3 such tables. And we discuss this. So upfront, there are certain things that tell us that patient cannot do. For example, we see patients who are older, 40s, and they cannot undergo myeloablative conditioning. So that's out then. If patients can undergo gene therapy, then they sometimes have preference in terms of, when patients hear about the 2 cases of AML, they don't want it at all, and they want to wait. We don't have the CRISPR. We're in the process of obtaining it at Sinai, but they want to wait for it and then do that. Some patients want to get over this as soon as possible, so they prefer transplant versus gene therapy. And this timeline is trial. All this is from the trials, so 1 to 2 months is not realistic in the real world. Age-wise, gene therapy is approved over 12 years of age, but patients treated have been in their 30s. So when we see patients in their 40s, we have to be clear that, this has not been studied in patients who are older. So that's a decision that we have to make together. And then after transplant, patients have to be on long-term immunosuppression. So some patients prefer not to be on it versus some are okay with it. Hemoglobin is something that I've learned that patients are particular. I want my hemoglobin to be 13 or 14. They're not happy with 9, 10, or 11. Event-free survival or survival-wise, they're very similar. Cost is different, of course. Coming back to our case, 40-year-old who had AVN of the hip, excellent performance status, haploidentical sister. The patient did not prefer to have transplant also, and the sister had autoimmune disease, so was not also cleared for transplant. The patient stated he would do anything, he would take any risk because he's 40, which increases the risk of complications. So we decided to do gene therapy. He underwent monthly red cell exchanges. We collected cells, which were good with the first collection. He underwent conditioning with busulfan, 16 milligrams per kilogram. Received cells 6.3 million. The minimum is 2.5 million, so this was good amount. 82% with the lentiviral vector positive cells, which is excellent. He had neutropenic fever, rash, no major complications such as ICU stay. This was his electrophoresis pre-gene therapy. This is without exchanges. So S of 80%, A of 9.1. Post-gene therapy at 1 month, 93% A, S 3.5%. At 3 months, 24.3 S. He's very unhappy about this going up. But this is expected, as I showed you. Is expected to go up to 45% by 6 months or so. So we're still at about 4 months. But this is expected, no crises. The patient states, I'm tired. When we saw him in clinic after the hospitalization, I'm tired, but I no longer wake up with sickle cell pain. This is the final thought I would leave you with. So each year, 300,000 to 400,000 patients are born with sickle cell disease annually in the world. We're fortunate to be able to offer these these expensive therapies to our patients here, which in the US it comprises 5% of the total population in the world living with sickle cell disease. And even with those 5%, we're not able to provide them with this option because of lack of access and obviously financially. There are consortiums, there are initiatives that are taking place to improve access, but there's still a very long way to go if we continue to move forwards and not backwards. And as they say, it takes a village. If I were to name everybody, it'll take another hour, but yeah, thank you to everyone.
Thank you for that incredible talk. I'd like to open up the forum for any questions. While you're thinking of your questions, I'd like to ask Dr. Ibrahim a question. So given the very differential expense between allotransplantation and gene therapy, have you, in your experience, how have you navigated the insurance obstacles given the multiple difference in expense if you have an option of offering both therapies to a particular patient?
So, when we first started doing this, we had a list of insurances which were no. So we wouldn't even see those patients, which is still the case. Unfortunately, it shouldn't be. If you ask me, and as a physician, I would say, I would see the patient, decide which one is best for them, and then start with the insurance process for that, and not look at the insurance first in the best case scenario. I personally don't look at that first. But if patients we can't see, we don't see, then unfortunately. No question.
Dr. Dunn?
Thanks for the great talk. We see a lot of these patients on the inpatient side, obviously, with connection with complications. I personally, I think as a team, we don't normally engage them in discussions about curative intent. We're concentrating on their acute illness. Is that a moment when we can start engaging people and finding out what they've learned in the past?
I would definitely, yeah. Any interaction. I mean, if you think it's the right, especially when they're acutely ill, I think they really want to get rid of that acute illness and for good. That's the goal of this talk. Thank you.
Oh, Dr. Chen?
Oh, I saw it.
Inspirational talk. I'm wondering if there's many big advances and additional advances in stem cell therapy, maybe iPS with derived cells. Are there things, potential trials in the near horizon which might improve upon existing technology?
Yeah, so the main one is in terms of gene therapy, there are trials looking at, so the main hindrance here for, especially for adults, is the chemo, busulfan, myeloablative. So regimens that were radioactive or otherwise antibody-mediated conditioning regimens that could get rid of the busulfan. There are ongoing trials with that to improve, and yeah, that would make more patients eligible for treatment.
Are we going to bring the CRISPR vector product to Sinai?
We're working on it, yes. Financial hurdles.
Excellent. If there are no further questions, thank you.